Now I'd like to introduce another speaker who also needs no introduction. Dr. Jaime Sepulveda is Professor of Epidemiology and Executive Director of UCSF's Global Health Sciences. Prior to coming to UCSF, Dr. Sepulveda held numerous high-level health leadership positions in Mexico, including Vice Minister of Health at the age of 36. So recently, only the last year I think he stepped down. But Dr. Sepulveda also worked on leadership team at the Gates Foundation, and he was vice chair of the Gavi board. And we are incredibly lucky and grateful to have him here at UCSF, and we look forward to his remarks. Thank you so much for listening.
Thank you, Catherine. Good afternoon, everyone. I'm sure many of us in this room have benefited from surgery. I certainly had. I had cataract surgery 5 and 10 years ago, and as a consequence, my life has literally changed. At the risk of providing you too much information, earlier this year, last January, before taking a long trip to West Africa, 3 weeks, to East Africa, I was advised by my surgeons to have a cholecystectomy because the risk of having a critical event in East Africa would pose certain risks. So it was an elective surgery, outpatient. In less than 5 hours since I entered the hospital, I was out. And the next week, I was playing squash. That's amazing. 5 hours, cholecystectomy, literally no pain, no consequences, and perfectly fine the next day. That is the magic of surgery nowadays. Now, the other amazing thing is that the bill came for over $50,000. And I will bring back that point because I think it's part of my main messages today. Now, I refer to the trip to East Africa. The team and I were traveling in Kenya. We were coming back from a rural village in the northern part of Kenya. And it was a Friday night, long day, coming back, huge traffic. Finally got to the hotel at night. We were so exhausted, we all wanted just to relax. But on the way to the hotel, one of my colleagues, Ryan Kidding, was run by a car badly. And he needed urgent surgery. We were fortunate, in a way, that that event took place in Nairobi, where he could benefit from pretty sophisticated surgical care. And he's fine. He had a broken femur. He needed plastic surgery in the face, but he's fine. He survived. He was lucky to be in the capital city. That is a luxury that many people do not have. Out of 7 billion people in this world, 5 billion do not have access to surgical care. So that is, to me, one of the most painful disparities we have in global health, and one of the most previously neglected issues in the global health agenda that, thanks to people like Khalid Abbas and Dean Jamieson, has been changed and now has surfaced to the top of the global health agenda in all our countries. So if you had asked me 15, 20 years ago whether surgery was part of the public health agenda, I would have said no way, that's a luxury. That is not for low-income countries. Well, that narrative has changed. That narrative, fortunately, and I'm quoting Atul Gawande, saying surgery is an indivisible, indispensable part of healthcare, but it is still treated as a luxury. So that is what needs to be changed. And both the volume of DCP3 Global Surgery and the Lancet Commission brings the numbers that we needed, brings the evidence that was lacking in terms of the burden of disease and the cost-effectiveness analysis. We knew from Dean Jamieson's DCP2, which I had to honor to chair to the advisory committee, to the editors, that 11% of the global burden of disease was due to surgical issues. That was the best estimate at the time. Since then, the estimates have been very exquisitely refined, and we have much more data on both the avertible burden of disease and the costs as well. I have 4 main points to make here rapidly. The first I already made, historically neglected, but thanks to these works, it is getting great momentum, and we should not lose that momentum. Second point, as Paul Farmer says, there are myths that we need to dispel. One myth is that surgery is too expensive for low and middle income countries to afford. Well, that is simply not true. Second myth is that this kind of 44 essential surgical interventions are not feasible in low resource settings. Again, wrong. And the third myth, and this is my own thought, is that surgery can only be done by highly trained surgeons. Certainly in the case of cataracts, we know there is the possibility of task shifting, task sharing, and I think that can apply to a number of other surgical procedures as well. So we need to dispel those myths. What do I see as the challenges moving forward? Well, certainly there's a challenge of scalability and implementation. Easier said than done. There's, of course, the challenge of sustainability and fundability. And I'll come back to the numbers. But then there's a third challenge that we should not omit, and that is quality assessment. The fourth point I want to make is that frequently we make the mistake of thinking global health is what occurs outside of the US borders. I want to emphasize global health is also local health. And global surgery needs to look, in my view, not only to the lack of access to surgery in low-income countries, but also to the overuse of unnecessary surgery. Certainly in my country of origin, Mexico, the number of C-sections done routinely, either for profit or convenience, are just horrendous. So hopefully the center will also take a look at the excesses as well as to the lack of. Numbers. If essential surgical procedures were provided, 80% of coverage, an estimated 1.5 million deaths would be averted. That's 7% of all avertible deaths in low and middle income countries. So there are 3 delays. Delay in seeking care, in reaching care, in receiving care. As many as 90% of maternal deaths could be averted by timely delivery of surgical services. Now, those who receive successful treatment, a quarter will face catastrophic financial losses as a consequence. So we need to make sure that surgery is incorporated into health insurances as an essential care. What are the costs? The estimates here sounds like impossibly high. The cost to reach the goals are approximately $350 billion by 2030. That really sounds like a lot of money. It is a lot of money. But think it from the other perspective. The cost of doing nothing, that is even much higher. $12 trillion projected losses in economic productivity by not doing. So that is a kind of evidence that we need to present to decision makers. So bottom line, after reading this, people will be convinced that investing in surgery is a highly cost-effective intervention, even in resource-limited settings. And we have to make the case that this is, in terms of burden of disease, equivalent to vaccinations, malaria, and HIV prevention. So surgery must definitely be part of the global health agenda. And here at UCSF, I'm looking at Ted now, I feel so proud that I got led the way by doing a lot of work, by training people, and now with this launch of the Center for Global Surgical Studies at UCSF, we are again at the leading edge of global health issues. I think the center will provide the necessary platform to address inequities in global surgery through research, through policy, through advocacy. I want to thank the chair of the Department of Surgery, Nancy Asher. I really want to congratulate both Rochelle and Catherine for their amazing leadership. And of course, it has already been said, Dean Jameson, Jaime Sepulveda were the early leaders of this movement, and we're very grateful to them all. Thank you.